and ask Sabyasachi. You see, today India has so much of anti-VEGFs available, and it's a huge burden. The patient comes and asks, "कौन सा anti-VEGF what injection will you give? Repetition कब होगा? And how many injections?" So I chose Sabyasachi to tell us about how to choose. So much biosimilars. Nitin Verma was talking about Eylea HD. Abhishek said that 4 milligrams से भी काम हो जाता है. So much information now available. So Sabyasachi, tell us how to choose now.
Thank you, sir, and very good morning to all of you. So I'll actually talk to you a little bit about choosing anti-VEGFs and what I do in clinics. And so how many of you think a lot of choice is good? Fans, do you think a lot of choice is good, or ek do hi choice is good? So how many of you think a lot of choice is good for us? Right. Many of you perhaps are not committal. We have a lot of choice, like sir has already told today. And so I thought I'll rejig this question in terms of positioning ranibizumab for the coming years, because in the next 4 or 5 years, we are going to see a proliferation of newer agents, such as tau inhibitors, tyrosine kinase inhibitors, genetic therapies. So then, and trust me, a lot of them are already in clinical trials. So by 2030, it is going to look entirely different. So are we actually going to even use ranibizumab or not is what we are actually trying and discussing. So some of my disclosures, some of them are with some of the anti-VEGF manufacturers, but whatever I'm going to talk to you is purely about choice. So like Sir has already said, and we have seen before, it has really evolved from the 2000s where we didn't have anything during my fellowship days to now that we have a lot of agents. So the therapeutic landscape has evolved from a one size fits all to really going personalized and evidence based, right? But then we all know that there are two realities, right? One is the science and one is the commerce. So Dr. Nitin in his first talk clearly about, let's talk about the money, right? So then science tells us basically what is good for the patient, and the commerce tells us what is sustainable. So our role really is to find the best balance, and I think we are all doing this subconsciously in our brains. So when we see these kind of swelling or edema, so many, so this is pretty much what is going on in our mind, the science and the commerce, and how do we balance all of this. So I'm going to give you a sort of a thought process on how I look at this. So every biology goes through this continuum of low exudative burden to moderate activity and then to aggressive activity. And I think our first job is to find out, given it could be DME, it could be RVO, or it could be AMD, where does this fall into? Is this a high exudative burden, aggressive disease, or is it a low exudative burden, basically mild fluid to a lot of fluid and some biomarkers? So the treatment intensity then should match the biology, right? So by low biology, what I mean in DME is less amount of fluid. In intermediate biology is more fluid with more hyperreflective foci and drill. And high biology, if you see, there's not a lot of fluid there, but all of those hyperreflective foci and drill that Dr. Abhishek was also talking about are there. So also a lot of images that Dr. Somnath showed, they all responded very well, but almost all of them had drill, and a lot of them had hyperreflective foci as well. Neovascular AMD, again, smaller PED, not much fluid. It's low disease activity. Escalate to intermediate activity where the PED is higher, there is more fluid, there is others, things like SHREM. And then, of course, high biologic activity like a PCV with a lot of fluid. So essentially, good candidate for starting with ranibizumab at baseline when his neovascular AMD is small to moderate CNV, no or minimal SRF. It's never going to be no. It's going to be minimal SRF, no hyperreflective outer HRF, no SHREM. SHREM is subretinal hyperreflective material. Then smaller PEDs and favorable anatomy. Well, less suitable are these very large ones like extensive CNV, persistent SRF, lot of outer reflective, HRF in the outer retina, SHREM, which is especially vascularized SHREM if you do an octa, large PEDs and polyps, and complex high risk anatomies. For DME, again, minimal or limited edema, no HRF, no drill or drawl, that is disorganization of the outer layers, and almost all of them are seen in the black and white scans, not in color images. Lower CST at baseline and motivated, reliable, and follow-up patients. And extensive edema with numerous HRF and drill, it's less suitable candidate for starting with ranibizumab. Right, so approximately, I think about 30 to 40% of our patients still would be good candidates for starting with ranibizumab. Right. So sequential treatment strategy of what I do is, start with ranibizumab, monthly initial doses. If they are responding well, like this patient did, then we, continue with that. And then we look at the top right is the 5-10 rule. That is loss of five or more letters or increase in macular thickness by more than 10%. It really suggests that there is not good response. So a patient like this who has a lot of HRF and drill but was not affording still went ahead with a biosimilar. Actually, the edema got worse at 1 month, so there was a switch to another agent. If you see the HRF has significantly reduced, vision has improved. So biomarkers are ideal, but then we have to put it together in terms of how the vision is, what is the exudative burden overall. So if you prefer simpler framework, this 5-10 rule also works quite well. So this looks pretty complicated. Let's look at this step by step. So the first one is to look at these biomarkers as well as vision, and then categorize into low, intermediate, and high activity in terms of exudation, and then initiate therapy to either ranibizumab or escalation. And then step 4 is keep evaluating at 5, 10, 15 weeks, and then look at these 5, 10. If there is 5-letter loss, and then there is also increase in macular thickness, we then switch over. Right. So essentially, the key take home message is that ranibizumab may be the first choice, but perhaps not in all of these. And also, these exudative burdens, it's like a continuum. So, what is the likelihood of the patient responding? Somebody with an aggressive disease might still respond to ranibizumab, but then the chances are not very high. So, if people ask me, what would you give your mother or your family member? And that's pretty much what we look at. So, the chance of response are not great. So also important to remember that neovascular AMD is a far more aggressive disease, so we need to hit it hard right at the beginning with loading doses of the slightly better agents. And that's because there is photoreceptor loss, there is fibrosis, and permanent damage sets in pretty early. So these are the AMDs which would do well with stronger agents right at baseline. A lot of outer retinal hyperreflective foci. If you see, these are some of these hyperreflective foci. There is SHREM here as well. So we call it vascular SHREM or avascular based on an octa, but any SHREM is actually a bad indicator. Large PEDs, there's a polypoidal vasculopathy. This PED is different from this one. This is a neovascular AMD with a PED, highly likely to rip and other things. This is a PCV. This is also PED, but looks very different. This is tall, peak, notched. And then, of course, high fluid burden. And these are still good for neovascular AMD to start with ranibizumab when they have smaller lesions, minimal or no SHREM, limited PEDs, no PCV, lower exudative burden, and therefore likely to have good response. Also, the economics is, I talk to patients a lot of times in terms of the EMI analogy. So, if you have large down payments, you will have smaller, easier payments later on. If you have a small down payment, you're going to have, continued burden going ahead. So, the costlier agents are higher upfront payments, but smaller EMIs and generally manageable. Whereas, this is pretty much what you can also use in clinic. So, treatment really can distribute its burden differently over time. So, if somebody is affordable, even, sometimes people who are not initially think they are not affordable actually then become affordable. Right. So I think it's an excellent ranibizumab is a good drug to start with lower disease activity, cost sensitive patients, good adherence, easy access to care. They're going to keep coming back to you with shared decision making, whereas poor positioning is aggressive disease, high risk of poor follow ups, long travels, high risk of defaults, and need for durability. So, does this apply to the retina? So, upfront investment in terms of how I talk is high acquisition cost is for faricimab or brolucizumab, whereas it's a lower, acquisition cost in the beginning, but then, the pain continues and you need to take too many injections. Also, remember that these dropouts are very common, and the CAT trial told us that after 5 years, actually, there is vision drop, even if you keep injecting a lot at the beginning. Right? So, every injection has two costs: one's the drug, and lot of these other things. So, it's very important to discuss. So, access to care, decide, match, and then monitor and then optimize. So, this is pretty much what we should remember is it's the best strategy is about the right drug for the right patient at the right time of his disease in the real world. Right? Technology, like I said, is evolving. Aflibercept, faricimab, TKIs, tau gene therapy, longer acting are really coming. So technology is evolving. Right? Principles still should remain the same. Look at the biology, match it to the biology, and then escalate if necessary. And positioning of ranibizumab, like I think I've already told you that. So beyond so that's a QR code I have written about this on my Substack. So you can take a look at that, and I write a few things in addition to retinal biology. So thank you so much, and I hope this thought process will help you.
Excellent, Sabyasachi. The claps say it all. about your talk. It's not an easy thing. Uh, I'll request the next speaker, that is Rupak, to be ready until the time is ready. What ultimately dictates? You said a very important line: one size does not fit all. And your basic talk was to start with ranibizumab. If Nitin Verma is there on the this thing, Nitin, are you there? Or I'll ask the other panelist if he's not there. Do you always start with ranibizumab?
So, almost never. Only if the patient cannot afford anything else, then we go for it. Otherwise, almost never.
Likewise, cost is the only issue why I would start with ranibizumab.
No, patient wants the best. Patient does not want the cheapest always. You see, if it is my eye, you see, remember, you see, this poverty in India or economics is overblown unnecessarily. If it is effective, I will spend more. If it is not effective, I may not spend.
So I would say beef with the presentation was that where you said that there is a lower burden of fluid or lower burden of a lesser aggressive disease. You may think ranibizumab, but in a lesser aggressive disease, a longer acting or a stronger anti-VEGF would do you wonders because then it will last more. You can go to PRN or treat and extend from day one. I mean, from the very next injection, you really would not need a loading dose. So my take is that eventually in Hindi we have a kahat na sasta roye bar bar.
So basically, the whole idea comes in because people don't afford, right? I mean, so the first, that's why I put the commerce thing so much up right and center. If the patient doesn't afford, then we look at so many other things. But then still, there is a way to look at it from the scientific angle, not just from the pocket.